you either have signs or symptoms with a lymphocyte count, absolute lymphocyte count greater than 5,000, you diagnose CLL. If diagnostic criteria is cytopenia, meaning you're seeing cytopenias, then absolute lymphocyte count of 5,000 is not a requirement. When you have novel splenic or extramedullary involvement without cytopenia, then you call it SLL, or small lymphocytic lymphoma. PLL, remember we talked about prolymphocytic leukemia, that's in the differential. When you have prolymphocytes greater than 55%, and they have strong surface immunoglobulin expression, and they are CD5 negative. Mantle cell lymphoma is another differential. It's a cyclin D1 positive, CD23 negative, CD20 and surface immunoglobulin strong positive. So the survival for CLL can be anywhere from 2 to 20 years. Median is about 10 years. Rye stage 3 and 5 and Binet stage C, which is the worst risk, have median overall survival less than 4 years. So they are the ones who really we need to be able to treat and improve their survival. You don't have to do a CAT scan of chest, abdomen, and pelvis in every CLL patient. You do it if they are symptomatic, meaning they have abdominal symptoms, fullness, or pain, then you do, or if you're doing it in a clinical trial. Stage 0, which is the Rye stage, the median survival is 150 months or 12 years. Stage 1 is 101 months or about 8 to 9 years. Stage 2 is 71 months or 6 years. Stage 3 and 4 is less than 2 years. What are the treatment options for CLL? You have purine analogs with fluorabine, pentostatin, alkylating agents, chlorambucil, cyclophosphamide, bendamustine, monoclonal antibodies, rituximab, ofatumumab, obinutuzumab, BTK inhibitor, ibrutinib and acalabrutinib, PI3 kinase delta inhibitors, idelalisib, and BCL2 inhibitor, venetoclax, and lenalidomide. All of these are available treatment options for CLL. So you have all these monoclonal antibodies, and there is always the question that comes up, what is the difference between a type 1 antibody versus a type 2 antibody? So in CLL, you're using rituximab and you're using other antibodies nowadays. The difference is, you can see the cartoon here. You have this antibody and you have complement-mediated cytotoxicity. So basically the antibody binds and then it causes cytotoxicity. Here it is antibody-dependent cell-mediated cytotoxicity. Antibody binds and then the cell binds and then that causes cytotoxicity. Here you have complement-enhanced cytotoxicity.